Hi everyone, I'm really thrilled to be speaking at this space this year. I'm going to tell you a little bit about my postdoctoral fellowship work, although I want to let you know that this is still at quite an early stage. So my fellowship is about non-specific symptom pathways for cancer, and I'm going to tell you a little bit about what that means and what my work is about. So firstly, I wanted to let you know a bit about non-specific symptoms. And really there are two types. There are the sort of undifferentiated non-specific symptoms. So this is where you experience a symptom in a specific place, like a cough, which is in your lungs, but it's undifferentiated because we don't know what's causing it. There are lots and lots of different diseases that might cause a cough. And then the other type of symptom is non-site specific. And these are symptoms that are not only caused by lots of different things, potentially, but we don't know which organ in the body are causing them. So these are things like weight loss and anemia and fatigue. And these are a real problem to investigate. Okay, so what happens when a patient presents with non-specific symptoms and the GP does suspect cancer? Well, what tends to happen is that the GP will refer them to one specialist in the hospital who's only looking at one organ system, for example, the bowel. But if they don't find cancer there, they might refer them to yet another specialist and still not have an answer about whether the patient has cancer or not. The alternative is a non-specific cancer pathway. So this would be where the patient presents to the GP, and the GP, rather than refer them immediately, would do a set of blood tests, which are commonly called the filter function tests, before referring them to a non-specific symptom pathway in a hospital. And the idea is that the consultant in the non-specific symptom pathway would keep investigating the patient until they can rule out cancer in all the major organ systems of the body. And for any clinicians among you, here's the list of those blood tests. So in my fellowship, I've been looking at how these new services are designed and organised, and how they sort of are creating this culture of investigating cancer, so that we avoid diagnostic errors, so that we avoid delays and we avoid ruling out cancer when there is one there. And so for me, that's about diagnostic safety culture. And I'm really interested in how we can use the sort of data and the research that I'm gathering to contribute towards future improvement and service design of these services. The staff in these services have a really difficult job to do. They have to decide where to start looking for a cancer, and you could say it's a sort of needle in a haystack. So they've got several bits of information that they can draw on. They have a referral form. They have the patient's electronic record for that trust. And they may have other bits of information electronically. And then, of course, they have the patient themselves, and they can ask the patient questions, which is quite often done over the phone. So all the services that I've been observing have a nurse-led telephone assessment where they ask the patients lots of information about their symptoms. There are also questions about how far the services are willing to go in gathering relevant information about the patient. So some are very holistic and will investigate diseases other than cancer, and we'll try and look for tests for this too. And others are more symptom driven. So if the patient, for example, says they've got a pain in their stomach, they'll mainly look at the organs around that area of the body. Many of the clinicians that I've observed and interviewed have described the process of gathering information about each patient as detective work, or likened it to detective work. And I thought this was really interesting, and that's why I wanted to talk about this today. It's obviously related to this sort of non-specific nature of the symptoms, and trying to decide where to look first, but it's also in relation to the quality and the nature of the information available. So, for example, it was often mentioned to me that GP referral forms were a source of frustration. They often had missing information. For example, the GP may not have written very much about why they were referring the patient. So they would give what they call a narrative about why they're referring, but it may be rather scant. So here's a verbatim example from my observation notes. The only thing that the GP wrote about the patient was she has a raised platelet count of uncertain origin. So the team don't really know where to look in the body. They don't know why the GP is particularly worried. They don't have any kind of salient information about the patient. The other thing that can make the detective work hard is when the GP provides out of date or missing blood test results. So you saw that large list of blood test results that I showed you on an earlier slide. Quite often some of those are missing. That can be a frustration. There can also be indications that the patient is being investigated for the same or different symptoms elsewhere, for example, at another hospital. So 3 of my sites are in London. North London is rather overcrowded for hospitals, and there are loads of them. And GPs will often send the patient to one hospital for a colonoscopy and then to a different hospital for the non-specific symptom pathway. But the staff can't see what the other hospitals are doing or see their results. And so it can feel like a really relevant source of information just isn't there. The other difficulty is that information is frequently stored on multiple information systems. So I'm sure lots of you are familiar with the kind of electronic record systems that hospitals and primary care use. I witnessed clinicians looking through 2, 3, or even 6 different information systems to find relevant information about the patient. So, for example, radiology reports might be kept on a separate system to the patient's kind of main electronic record. They might have some kind of version of primary care records that they can refer to. But sometimes that's kind of very minimal. They might be able to see laboratory results on a separate system and so on. And so it takes a really long time to log on to all of those systems and find the relevant bits of information that might tell you something about the patient. So I wanted to talk a little bit more about why a narrative in the referral form is so important. So when I talk to clinicians about what they want to see on a referral form and how it can help them make decisions in the hospital, it seems to come down to 3 things. They want to see some evidence of diagnostic logic from the GP. So, for example, they want to see that the GP has had a good think about what could be wrong with the patient and has investigated it as far as they can. They'd also like to know what's normal for the patient. So, for example, has the GP measured their weight several times over the last few years? How do they know that this weight loss is significant, for example, and any other trends over time or significant information like bereavements or new drugs that the patient might have been on. It's also helpful if they can tell them a bit about recent episodes of illness or other reasons why their appetite might have decreased. And the third thing is to know what has definitively been ruled out. So what other investigations have been done where they can say that there's definitely no cancer, for example, in one organ system in the body, so that those non-specific symptom clinicians can just strike that out and disregard it, to take it off their list, if you like. So another part of this detective work that I thought was useful and interesting to talk to you about was the way it was captured. And this was really variable. So having spent, let's say, up to 15 to 20, maybe 25 minutes finding out lots of information about the patient, I discovered this was rarely captured in any meaningful way, i.e. having gathered all the information together, it then disappeared again almost immediately. So some staff would write down the salient details that they'd captured in something like a notebook so that they could present it to their colleagues later, or it might go in a diary. So some sort of paper format. Others might write each other a 4 to 5 line email summarizing what they'd found out and maybe asking someone else in the team to book the relevant tests for that patient. And in some hospitals, there was a template or an electronic health record pro forma where this could be captured. So there might be some tick boxes where they could fill in the information that they'd gathered about the patient. But even then, the details that they had so painstakingly gathered were often simplified down to sort of bare minimum of information. For example, the patient's comorbidities or previous weight results. And I witnessed that this resulted in further duplication of that detective work later on in the patient pathway. So, for example, when the same clinicians would come together to decide whether or not to discharge the patient from the hospital, they would do that work again of looking through this 38-page referral form and all of the relevant electronic medical records. So something about capturing the detective work is really important and something that could be improved. So with that in mind, I wanted to suggest some obvious targets for improvements so that we can reduce this sort of huge burden of detective work, which seems to be really a necessary part of investigating patients with non-specific symptoms in the context of cancer. A really, really obvious one is to make improvements to referral forms. And at a local level, I've started helping teams with this, think about how they can do it better. But I've also secured some further funding to explore this in more depth over the next couple of years with a researcher. Another really obvious thing would be to make imaging reports from other trusts available. So to have some sort of database. I know that there are real difficulties sharing information between trusts, but I think radiology may be a very specific target that would have a huge benefit in this context. Then some less obvious potential improvements would be perhaps the development of some AI-based tools that could mine or kind of search through the relevant information on these systems to capture it from all these different forms and electronic health records to present the clinicians with a summary and to make sure that nothing's missed. And finally, I think it'd be really helpful to investigate some better methods of capturing that detailed information so that it's not lost during the patient pathway. That's it from me, and thanks very much for listening.